interest to come. We really do appreciate that. Humphrey Megere, work with HCI in Uganda as Chief of Party. We shall be making this presentation with Dr. Nigel Livesley. Doctor, you can start.
Thank you. Hi, everybody. Yep, Friday afternoon, Paris in the spring. We're happy that anybody showed up, so thank you very much. So we're going to be talking about some of the work that's been going on in Uganda to improve care for chronic conditions. And we're going to talk practically about the work in Uganda, but we're also going to be talking more broadly about the issue of how to deliver care for people with chronic conditions in systems which were really set up for managing acute problems. And this is really the situation all over the world. Basically, every healthcare system was set up to deal with acute infectious diseases, problems of childbirth. And the situation is really that systems are set up to make a diagnosis, find out what disease that person has, and then to manage that disease. And the interaction is often between the healthcare worker and the disease, and the patient is sort of there, but not a major focus. And that may have been appropriate in the past. There are some efficiencies with just managing that condition, putting people together with the same types of problems. But with the change in epidemiology, where the issue is now more chronic conditions, that's not appropriate any longer. First of all, because very few people have one chronic condition. They usually have multiple conditions which go together. And so they end up being managed in multiple different places, which is always a problem. And the second, and probably more important problem, is that if you're leaving the patient out of it, you are leaving out the main caregiver. Anybody with a chronic condition is, by default, the main caregiver of what they're looking after. They are the person who's doing it day and night, every day, every week, all the time. We might see them an hour a month in the clinic. The other 719 hours, they're on their own. And so as chronic conditions become more prevalent all over the world, the systems are not really set up to deal with that. And this is one of the big challenges that we're struggling with. So for today, we're going to talk about a few different things. We're going to talk about what are some of the challenges with managing chronic care conditions in a system for acute care. We're going to talk about some of the theories that can be helpful for deciding how to change your systems, and then we'll give some practical examples from Uganda. And I'm going to ask Martin to stand up for a second. Maybe you could stand up. So Martin has been leading this work in Uganda. So we're going to be presenting, at the end, we'll be presenting a lot of his results. So thank you. And we're going to have this as an interactive session. You have a workbook, and so you have to do some work. We thought we didn't want to talk for an hour. We'd rather share the labor on a Friday afternoon. So we're going to start by asking you to sort of form small groups. You may wonder why the room is set up as an audience lecture when we're asking you to sit in small groups. If you're critical, you can blame our organizational skills. If you are charitable, you will thank us for inspiring you, because we're asking you to talk about how to provide acute or chronic care in a system which isn't set up for that. And we're asking you to do that by having small group sessions in a system which isn't set up for that. So the first things we want to talk about, or ask you guys to talk about for about 5 minutes, is maybe find your neighbors, get together, and talk about what are some of the differences in how patients with acute and chronic conditions interact with healthcare. The second question is, what are some services that people with chronic conditions may need, which are different from those with acute conditions? And the third, just to sort of reflect on how well your health system meets those different needs. So this is obviously a bit of an oversimplification. The split between acute and chronic isn't always helpful, but just to get thinking about it. So if I can ask you just to spend about 5 minutes, find a neighbor, have a discussion, and then we'll get everybody back. Okay. Hi, everybody. We come back together. So let's maybe just, I don't think we'll exhaust this, but let's go through some of the ideas that people have. So what are some of the differences, key differences between how people with acute and chronic conditions interact with the health facilities?
We talked about one of the key points being the consistency in terms of patients with chronic conditions having to visit facilities on a more regular basis over a longer period of time.
Right, which is random. They can't predict it. Oh, yeah, sorry, we should going to do the microphone. Thank you. Yeah, so she was saying the sort of regularity of appointments. People with chronic conditions have to keep coming back, regular basis. People with acute conditions, it's random. They wake up, they're sick, they go to the hospital or wherever. Anything else?
Hi, thank you for your presentation. I think that people with chronic diseases do want more involvement in how they do their care, how the care is done to them, and that's different with patients who are in acute care.
Right. So they have to be more involved and more active. Yeah.
And I think in our setting in South Africa, you find the acute patients are more keen to wait long hours because they know it's a one-case event.
Right.
Whereas if they're chronic patients and you tell them they must come often, they skip most of their visits because they don't, it's kind of unacceptable to them to wait for 5-6 hours every time they come for their chronic medication.
Sure. Yeah, convenience becomes much more important. Yeah. When the visit is getting in the way of your life. Yeah.
I think we came up that maybe people with chronic conditions, they may have to see specialists, different specialists all the time. But also they may not have priority within when there's scarcity of resources.
Sure.
They're just told, well, you go home and manage yourselves, and then if you have more problems,
right.
Then
yeah, people talk about the tyranny of the urgent.
yes.
Everybody prioritizes the things that are really important that day. People with chronic conditions, it's often not that important that day, but over time, it kills you. Yeah. Should we take one more and then move on?
The other thing that we have in South Africa is the fact that in most cases, those that have chronic conditions, they've got is sometimes more than one condition, and unfortunately they have to queue twice or 3 times because the services are provided in a fragmented manner,
right.
And therefore sometimes they spend more hours than they actually should be spending at the facility because they have to queue a number of times as
right.
compared to acute patients.
Right, so we're still treating diseases, not people. Yeah. And what are some of the differences in what they need? People with chronic conditions, what do they need that is different from people with acute conditions?
If you look at an acute condition, it's more about fixing the job, so you can probably go back and manage your chronic condition. So it's a problem that's come in the way of your chronic condition. You need to go fix it so you can get on with your chronic condition. In a chronic condition, it's more so perhaps the question that was raised in the first presentation with the keynote speaker is what matters to you the most. Whereas in the acute, it's what's the matter.
Right.
So it's a differentiation of the two there.
Sure. Yeah. And there's somebody at the back.
So I think if someone's got a chronic condition, then the service is about treating that condition within their whole life and how it impacts on their whole life, which is different to someone presenting with an acute condition.
We also said that the families tend to bear the burden.
Right.
They're just go back to the family,
Right.
but also their needs are that they themselves are experts.
Right. The patients and their families have to be much more involved.
Yeah.
Right. So, with most visits, the focus is on diagnosis with acute conditions. That doesn't happen with chronic conditions. The diagnosis was made 10 years ago, or however long. And there's usually no change in diagnosis, no change in treatment either. And so acute care is really responding to problems of the past. But chronic care really should be about preventing problems in the future, making sure that patients can look after themselves until they go home, until they come back and see you the next time. So it's a lot of the focus on the future, which is very rarely done, or done poorly in a lot of places. And, as we were saying, the patient's role with acute conditions is pretty slim, pretty small. It's a lot longer when you have a chronic condition. You have lots of responsibilities. And so there's lots of things that they need from the healthcare system. They need information. They need to know about how to look after themselves. They need skills, specific actionable skills that they have to pick up. They're not simple. Taking pills is not something people are good at on day one. They have to learn to do it. And there are other skills which become even more complex, with diabetes, for example, taking blood sugars 4 times a day. And then there are lots of other issues that they have to learn. How to deal with the fact that you're sick. It's not easy. How to be motivated to look after yourself. How to feel confident that you can do a job that seems pretty medical. Right? These are all things that are unique, that people with acute conditions never had to struggle with, and so our systems are not really built up to deal with them. I'm not going to go a lot into the chronic care model. Actually, that's it for the chronic care model. But we're going to move to Uganda and talk about some of the work going on there. So Humphrey is going to do that, and then we'll break into a small group. And if you have questions about the chronic care model, put your hand up and we'll come around.
All right, thank you very much, Nigel. Yeah, in Uganda, we try to address this issue of chronic conditions, and we identified with the Ministry of Health one rural district where we went and worked with the health workers in that district to try and address the issues of chronic conditions. This is a district which is rural, about 50 kilometers away from the capital city. It has a population of 400,000 people, 5 hospitals, and about 10 health facilities that below the hospital level. Now, when we looked at one particular hospital, because there are 5 hospitals that we chose for this purpose to show you some of the data that we found in one of the hospitals in that district. And we want to see whether the chronic conditions were being managed the way they should be managed, or they were still using the acute model for managing chronic conditions. In this particular hospital, Wiko Hospital, in 2010, they had a catchment population of about 34,000 people, and out of that, we expected about 1,445 patients with HIV, 4,000 patients with hypertension, and about 80 patients with diabetes. But when we looked at the data in the facility, HIV was doing relatively well because they had a track of records of the patients who have been getting care in the facilities. They had 311 patients who had ever been enrolled in care. Out of that, 258 were currently getting treatment. And out of that, only about 188 had good clinical outcome. Good clinical outcome for us, our definition was if a patient is not getting opportunistic infections, if the patient is clinically well and is not losing weight. Now, when we looked at hypertension data, we couldn't get any information from the records on the number of patients who have ever been enrolled in care. Though patients have been coming, but they're being managed in the outpatient department as outpatients. There was no data on how many were currently in care, and nobody knew how many had good clinical outcome. Same thing with diabetes. There was no data on how many people have ever been enrolled in care, how many were in treatment, and how many had good clinical outcome. We looked at the various components of the chronic care model. Self-management, this is where the patient is able to manage his or her condition. The system for delivering these services, whether or not there are records and registers for these conditions, and community linkages, because with chronic conditions, you need to have a strong community linkage and support. Also looked at availability of register, of guidelines, of protocols to guide the health workers to manage these conditions well. In all these, HIV seems to be doing a bit better because the HIV program has been going on for some time. They did have some form of self-management, mainly basically health education. All the patients were seeing the clinicians, whether they are having a problem at that time or not. But they did have records, and registers were well kept, but there were no community linkages. Though also they did have some guidelines to help the health workers make decisions on care. For hypertension, nothing about self-management, nothing on the system of delivery. When patients come, they're managed as outpatients. The information system, all the patients who had hypertension and diabetes were registered in the outpatient register. There was nothing like longitudinal data to follow up the patients to see how they're performing. There were no community linkages, and there were no guidelines, there were no protocols to help the health workers make decisions on how they can manage hypertension or diabetes. So we thought there was a problem here, and we want to work with the district to identify some solutions to some of these issues. Now, we had some questions again here for discussion. As you have seen, there are some good points that we could see from HIV, and we want to know if you have some ideas on some of the priorities for HIV care that we could put in place, and some of the priorities that you think we could have thought of for hypertension and for diabetes mellitus. And to look at some practices from HIV, some good practices from HIV that could be transferred to hypertension and to diabetes management, and changes that you think could be implemented at the site level, and changes that you think need to be taken at a higher level. But because of time, we may not have to go into this, but I'll just share with you what we did in that district and in that hospital. As you have heard from most of the low-income countries, one of the biggest problems that we have is manpower. We don't have enough health workers to support all the patients. So what the district and the facilities decided on was to work with patients who have been on treatment for a long time. We called them expert patients because they've been on treatment for a long time. They are stable now, and we wanted to work with them so that they could work as peer supporters for fellow patients, to help them when they come to the clinic, to share their experiences with them, to help even with some little work at the facility, like retrieving files from the cupboard and organizing the lines as the patients come. And we also the health workers in the facility also agreed to do triaging. Triaging is where they make sure that patients who have acute conditions, who would need to see clinician, are lined differently from those who are just coming, who have chronic conditions and want to get supplies. They don't have to be in the same line. Because of this, it was easier for patients who are coming to pick their drugs to go straight to the pharmacy and pick their drugs, and those who have complications would be the ones who would be taken to see the physician. Health education also took another another angle where we had patients having a one-to-one discussion with a health worker. Each patient definitely is different, and each one had their different issues, and they discussed this with our health workers to set goals, personal goals, on how they're going to be able to manage their conditions. At the beginning, these were very modest, but as we went on, all the facilities were implementing this. And we did something for each of the conditions on self-management, on the delivery system, on the information that needs to be available, on the linkages with the community, and also got some guidelines and protocols from the ministry to help the health workers make good decisions. Having done this, we were able to see some good changes. And as you can see from that graph, the number of patients with HIV who got into enrollment increased tremendously from October in 2010 to November 2011. And those who remained in care, also the number could see that it was fluttering, but it was increasing. And what is important is that because of self-management and community linkages and all the other components of care, the number of patients who are getting better, who are getting good clinical outcome was increasing, and you can see the gap between patients who are active in care and patients who are getting good clinical outcome really narrowing, meaning that more and more of the patients who are in active care are getting good clinical outcome. What really surprised everybody was that diabetes actually was a problem in this rural district and in this facility. But because we didn't have data at the beginning, we thought there were not as many patients with the diabetes or with hypertension. But when we began having longitudinal records, getting every patient with hypertension, with diabetes recorded, that's what we found out, that actually there were many patients who were with hypertension, who were with diabetes, and who needed care and support. And we also saw that because of the interventions that we had put in place, the patients with hypertension who were controlling the hypertension into the acceptable range was increasing. Likewise, the patients with acceptable fasting blood sugar was increasing, meaning that they were able now to manage, more and more patients are now being able to manage their conditions. However, we still do have some challenges. We need to really improve our care and also to improve on the outcomes. Still, there's many patients who are not getting better clinical outcomes. We need to make sure that everybody who is actively in care eventually gets a good clinical outcome. And we are still having a problem of making sure that we retain all the patients in care. Many times, some of them drop off, and we need to find reasons why and help them to remain in care. And we are working with the Ministry of Health and with the district to ensure that what is happening in this small district can be replicated in the rest of the country and in the Ministry of Health as a policy. We are not able to do this alone. We want to acknowledge Martin. I think Martin was here. He has been the one who has been championing this. We also have been working very closely with our patients in the district, with the Ministry of Health, especially the AIDS control program, and the Department of Quality Assurance, as well as the Department of Clinical Services, and those other people who are listed in that slide. Thank you very much, ladies and gentlemen. Okay, I think now we can take some questions. Comments, please.
Just a quick one. Thank you very much for sharing your story. I think it's the graphs show what an impact it had. Do you have an impression in terms of which intervention was the most impactful in terms of the outcomes, based on the different kind of areas? So the self-management versus the clinical guidelines, for instance.
I think it was a combination of factors. One was the interaction between the patients and the health workers played a very big role in ensuring that patients come once, they come back on the second time, they come back the third time. But also the fact that the patients were now able to know their conditions, because like diabetes and hypertension, most of the patients didn't know that this was a lifelong condition. They thought if they feel better, they can get wind of the drugs. So the ability for the health work, for the patients to know their conditions, that it's a long-term condition, and they need to do something about it, I think also helped and motivated the patients to keep in treatment. Yeah. But as I said, it was a combination of all these other factors, the records keeping, the community support, but I think those two were very critical.
And that's sort of what research on other places around the chronic care model shows. You know, it's unlikely that one thing fixes everything. You kind of need a bit of everything. Yeah, and but it's hard to avoid the impression that self-management is absolutely crucial. And the research probably supports that a little bit.
Hi, this is Patty Webster with IHI. I think this is fantastic because I think that there's a lot of us dealing with the retention of care issue, and I know you noted that as a challenge. I'm looking at the graphs, and I think it's fantastic in the enrollment of patients with diabetes and hypertension. And I'm wondering, what was the retention of those patients? Because I see the graph of your enrollment with HIV patients went up, and I love the fact that you see the narrowing of the good clinical status, but I also see that there's a widening of the retention for the HIV at the same time. So I'm wondering, and I know you mentioned as a challenge, so what are you going to do about that now? And how about with the other chronic conditions? Do you see that same problem with retention? And I'm wondering, you list links with the community. Are you trying to take the care out to the community so it normalizes the care and involves it in their everyday versus having them come to clinics? Because we're grappling with this in some of the work in South Africa. So I'd love to hear kind of thoughts on what you're thinking of doing for next steps. There's a lot in one question, so I'm sorry.
I'll try, and then my colleagues will chip in. Retention really still remains a big problem for us. HIV, diabetes, hypertension. And I think about 2 weeks ago, we were trying to understand this, and we went back to the district to try and find out what the problems could be. And I think we haven't really figured it out. Many patients they self-transfer to other districts. Others, when they feel better, they don't come back. But really, it's a big problem. We are still trying to figure out how to handle this. We don't have a very clear answer yet.
How about the hypertension and diabetes patients have other conditions? Are you retaining them in care? Do you know? Are you measure that?
Yeah, I think we didn't have that graph here, but we are following those up also, and still retention is a problem for hypertension and diabetes as it is for HIV. Yeah.
And I think people mentioned some of the problems already. You know, that you've got lots of visits, that it's not convenient, there's long waiting time. So it's going to require lots of things to address it. So Mabel, do you want to say something about what you're thinking of doing in the community? So Mabel is in charge of doing some of the community work to try and address that. And then, sorry, I'll give it to her now.
Thank you, Nigel. My name is Mabel Namwarira, and a quality improvement advisor at UCAID in Uganda. Excuse me. My work is going to be, primarily deal with the communities, and the aim is to try to improve the follow-up and self-management in the community. Because patients spend most of their time in the community, and there are so many factors that influence their decisions, influence their ability to take medications, their appointment keeping. So we are planning to build a community system that will involve the Ministry of Health structure, which is called the Village Health Team. These are individuals who willingly decided to take part in mobilizing community, supporting patients in the community. It's the first level in our primary health care, which is called level 1. And these are individuals who follow up patients in their homes, counsel them, and provide all the necessary support they can in the community. So this is going to bring together all community structures that involve churches, schools, local leaders, patients, expert clients, and the village health teams together to see how we can support the role of what we call the village health teams to make care better for patients, divide up roles, follow up patients in a more regular manner to see how we can improve retention of the patients in care. Thank you. Any questions or clarification about what I've said? Yeah? To me or? Okay.
Thank you. I think some of the questions I was going to ask, you already answered them, but I just wondered, the medication that you gave, is it free? When they come to, because they have chronic conditions, and if they have to come back for the services, is the service free? And also, perhaps, is it about those people, are they working? Is it loss of livelihood versus coming to hospital? So,
okay, we do have 3 types of facilities in Uganda. We have the government-managed facilities where services are free. All the services are free. Then we have private, not-for-profit, mainly managed by the religious groups, the churches. Those services, they are subsidized heavily. Patients pay some money, but it's not really to recover the costs that have gone into procuring their services. Then we have the, obviously, private facilities that make profit.
but is the retention rate across the same area?
Well, I haven't done that, but maybe Martin, do you have some response to that?
Yeah, just to add on what he said, that we did a survey, or we went in to ask the patients and the health providers what could be the cause of poor retention, why patients are not coming back. And among other things we found out was the issue of cost did not come out, did not appear, because patients choose to go wherever they want because of the comfort and, the interest. Things that came out strongly were issues like transport, distance, and especially in HIV/AIDS and others, like they have more drugs. So they thought because they had were given excess drugs, there was no need of coming back, and so they stayed behind. So we want to build from these and the other, findings, but these were more. Were weighing more than the other reasons. So we want to see how do we move forward? How do we work with the patients, work with the facility teams, providers to address some of these reasons that are coming up? But the issue of cost, or paying, didn't come out, because in any case, at some of these facilities which that are private, not for profit, a patient just pays $1 to $2. It just ranges between $1 and $2 for consultation. But this includes consultation, treatment that is given. So it was not a big issue. Yeah, that was their concern. And so some facilities have started addressing this in kind of establishing outreaches. That when they at one facility, they call them consolidated outreach. It's their term. That when they go in for an immunization outreach, they also they go with a package for chronic diseases. They go and screen and go with some drugs so that whoever is seen from there is given drugs, and then, instead of coming to the facility, that one reduces on the cost. And then those who are screened and found positive, hypertensive or diabetic, are referred to nearby facilities where they choose to get care from. And we think that one is going to improve care. Thank you.
Did you have a question?
Okay, sure.
This is just my own discovery. You know, this HIV, the stigma behind it, some people don't want to be recognized or be known for that issue. And they would prefer, instead of coming back to the clinic again, they prefer to have their own private doctor and will never come back again. And that could be a cause of those patients not coming back again. They prefer, they don't mind paying for it, and get their own doctor and will never come back to the clinic again.
Yeah, I think that's true. That's true. Any more comments or questions? Good. Thank you very much, everybody, for coming for this session. We really appreciate your coming, given that one of the very last sessions of the conference.
Thank you very much.